from the new technology that they changed it. Okay, I'm going to talk with him anyway.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our
telling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.
Oh, I have to turn on the music maybe. They gave me such a headache. Oh my God. Welcome to the MedBix webcast. This is Ramana Anamraju. Sorry about that, guys. I am having a lot of hard time. They changed the entire platform. It is all mixed up, maxed up. It is a new learning curve. They need to have a tutorial or something, but it's a great platform I've been using for more than a year, and it is really changed everything. A little bit of a challenging times I have with the technology now. I am in the middle of Silicon Valley. Think about we struggle with the technology. Outsiders, it's so when the people say it's easy, is not. Is we have to go a long way with technology to be really assisting and helping understanding the natural language. So that is a long way to go. But anyway, without a further ado, I want to bring my guest. If it is possible that if I can get him on the let me bring him both of us together. I don't know whether it is. Yeah, let me see. God, I hope. Yeah, something I can see that. Okay. Dr. Lewellis, thank you for coming. Sorry for the trouble here. We have saw a lot of problems. This is a new technology. They changed it to the complete platform this month and the last week, and I've been struggling. This is not my regular struggle, but a special struggle.
That's okay.
Yeah.
That's all part of it. Just rolling with the punches, and you never know what's going to come up. I appreciate you having me back, and I'm happy to be here.
Dr. Lewellis, I'm always a pleasure to have you back. You are one of the leaders I admire and I follow. I wanted to ask you, just give me, Dr. Lewellis, can you give me a little bit of your little bit of your background? You did a PhD. I'm a scientist. A little bit, give me what kind of thesis you did on PhD side. Then we can go into the little bit of your practice side of it later on.
Absolutely. Thanks for asking about that. Always happy to delve into the past a little bit. I don't get to talk about that much these days, as I'm primarily doing clinical medicine. But my PhD was in the developmental genetics department at New York University School of Medicine, and I studied under the in the lab of a professor named Holger Knaut, and he was fascinated by the way that in early embryogenesis, the way cells get to where they need to go in an orderly and repeatable and reliable fashion so that they can come together to form organ systems. And the way that we studied this was using a model organism called the zebrafish. And the advantages of the zebrafish is it's a transparent embryo and a very genetically modifiable embryo. So we can put certain genes into it. We can take them some out. We can tag proteins with fluorescent proteins so we can watch them in real time moving around, things like that. So a lot of my work was elucidating the fundamental chemical signals using chemokine signaling that cells use to figure out where I'm here. I'm in this big ball of cells, and I need to go somewhere to do a job essentially, and the signals that they use to get there in again a reliable and dependable way. And we by kind of screwing with that process in certain ways, we got to see, okay, if we do this, then this happens. If we take this away, this happens. If we put too much of this happens. And then we kind of make a model. And you would have loved it because we brought in a physicist at the end because he helped us make this model, this sort of gradient that we elucidated for this kind of a novel way of cell migration that used a gradient of this chemokine that was generated by the cells that were actually moving and following the gradient. There was a self-generated gradient to keep them moving in the same direction. And we collaborated with a physicist to help model that out for us. And that was way beyond me. I was very grateful for his assistance. I love learning about math and physics and hearing about it, but I don't I don't grasp it on a fundamental level. I have trouble with that. But thanks for asking.
That's very interesting. A self-generated gradient. You said that itself is a mystery behind it. So that's a looks as a couple of three words, but it is a deep mystery behind that, the nature itself. Yeah, yeah. Thank you for joining. I enjoy that. That always understanding the difficult part of the cell communication is always wonderful to listen to. And as a physicist, as a thinking, as outsider, that is really, really fascinating to me. Now, after you did a PhD and a MD in Stanford Medical School here, right here, a few miles from here. You did that. Tell us that experience a little bit.
That was a wonderful experience. I was really blessed to be able to get into that program, the dermatology residency at Stanford. Really, any dermatology residency is tough to get into, but one like that is especially so. And I fell in love with the program the minute I showed up on my interview day. And I actually screwed up a few of the interviews, I thought at least, because I was so nervous. I had felt like I had a panic attack in a couple of my interviews, and I even ended up. It was so bad in my perspective that I ended up reaching out to the faculty members who were involved in those interviews and just apologizing. Essentially, I said, I screwed up. I'm just sorry that you had to be there for that. I had such a hard time telling my story, and uh, I honestly think that vulnerability, that authenticity was part of why they perhaps were drawn to me, which I felt like I needed some. I wasn't doing it intentionally, but it was nice to have a leg up. The people you're competing against to get a spot like that are really incredible. So I love the folks I was with while I was studying there. The faculty are all amazing. The chair of the department there, Paul Kavari, also an MD PhD, runs a huge lab, probably 30, 35 people in it by now, tons of postdocs, grad students doing remarkable stuff in the genetic basis of skin disease. And then the program directors at Stanford are incredibly nurturing, beautiful teachers, and really just want people to succeed and also have a good enjoyable life. Even though it's residency, it doesn't have to be miserable. It should be hard, it should be rigorous, but they made sure that it wasn't misery by design, at least. And so many things I'm grateful for, and I'll always remember that experience. And actually, while I was there, I got to spend about a month in Nepal at a Dhulakal hospital, their dermatology department there, learning from them. And I learned an incredible amount from that group over there. And I look forward to continuing to be in touch with them and collaborating with them. I just spoke to someone I met there just yesterday. I interviewed him for my podcast. He's at Johns Hopkins School of Medicine, or Johns Hopkins Public Health School right now, from Nepal. He's spending the summer there as a summer scholar. He finished medical school in Nepal, and he's a real rising star. And I look forward to seeing where he goes. So yeah, lots of good memories from Stanford. I was very grateful for that.
Yeah, just you mentioned Nepal. So panic attack. Don't worry, I get panic attack every time I come on podcast. But I want to ask you. Just you mentioned Nepal. So what is that? The latitude and all those heights. Does it create a different kind of a pressure on the skin, or do you see different kind of pathologies there in those areas? Actually, that because you mentioned them, just I'm curious.
I'm sure there is if you drill down hard enough, I'm sure there are some differences in terms of the pathology just based on position on Earth and the relationship to the sun and things like that. But what I noticed more so was that because it was coming from a place where I was seeing a lot of people with light colored skin like me who are prone to getting skin cancers, especially in their older age. A lot of people would come into dermatology clinic for some sort of spot. I'm worried this is cancer, this mole I'm concerned about. You go to a place like Nepal and people are sometimes have concerns for skin cancer. And that honestly tends to be the easier stuff because you just look at it. Do we biopsy this or not? If it is cancerous, that can be hard to deal with, but it's not much of a puzzle or a detective story. But in Nepal, there were such a wide range of rashes that were related to some inflammatory, some infectious, some even could be cancerous, and things like cutaneous lymphoma. And it was a great challenge for me being able to see all these entities in people with inherently a darker skin tone, because that's harder as well. You don't see the inflammation as easy as you would in someone like me. We always say things are erythematous or pink or red, and that's not true. It's true in me, but it wouldn't necessarily be true in you. If we had the same rash, mine would look a lot more red than yours would, but it's still the same thing. And that's a good thing for a dermatologist to remember, and good training to seek out, because we really need to do, in terms of equity, we need to be able to recognize these things in a timely fashion in all different skin types. But it was a lot of more challenging cases than I would see in a typical clinic environment at Stanford, for instance. So the rigor of it, the residents were incredibly learned. They knew the textbooks front and back, and their attending physicians held them to a very high standard, and they didn't have the tests that we have to rely on. Sometimes you could do a biopsy, you could do some advanced imaging kind of things, or we were trying to bring an immunofluorescence program to their hospital, for instance, but they didn't rely on it like we do. They used it when necessary, but they conserved the resources because the resources needed to be conserved, and people were paying out of pocket for all these things as well. So they were using their brains a lot more than they were using microscopes and sending off for tests. And I'll always remember that about them too, because we lose that. We're plenty smart here. We can memorize a lot of stuff, but we lose that hands-on kind of detective work of medicine sometimes when we become over-reliant on testing.
Interesting. Did you go to the Everest? Did you climb Everest or base camp? At least you went to the base camp.
I wish. I didn't have any time for trekking. I was working most of the time I was there, but I did get to explore some areas and had my roommate while I was there did do some trekking, and he told a very scary story about a mudslide that happened while he was there. It was I'm glad I didn't, but I did see some amazing sights. You could see from the guest house I was living in this village, Dhulakal, It was on top of a hill, and every morning I would look out in the clouds, and every once in a while I would see Everest peaking in the distance, and just an unbelievable country. The the sights, the people, the food, the culture, everything about it. Hospitality is the biggest thing I remember, and that's a big part of my practice. Had the way that people made me feel, regardless of the amount of resources they themselves had, was memorable, and I try to apply that here.
As it's strange, it may be, but actually, I'm very closely connected with some of the actors from
Oh,
Nepal. So we actually inviting next week, August 15th. Actually, there is a August 18th. One of the famous Nepalese actors, Manisha Koirala,
great,
she's coming to India Independence Day parade in Fremont, California. Actually, she's from Nepal originally, so she's a Bollywood actress. So she
wonderful,
is coming here. So I'm going to tell you your experience about that. It's
that's
interesting.
exciting. Yeah, for
Uh,
sure. That it's a great culture. I was really fortunate to be able to experience it, and have friends, lifelong friends and connections now. The other physicians, and a doctor I was talking about was a medical student when I was there, and now he's really going places. And he'll be on probably in a couple months. My podcast will have my interview with him, and you can look out for that. His name is Dr. Niroj Bandari, and he's super smart guy.
So you did a quantum jump from that side of the Midwest all the way to the. Tell us that experience.
Yeah.
Why you are a Stanford educated, MD,
Mhm.
PhD, dual degrees. You could have pointed anywhere in the world. Just put your finger, you would have got the job. So how did you end up in Wausau County in all the way Midwest? Land of tell us a little bit that
Sure.
experience and
Sure.
journey there.
My strongest connection to this area is my wife. She grew up right in this area where we live now, and her parents still live close to here, about 15 minutes away from us. But we met at New York University. That's actually where I did the MD PhD program, the medical scientist training program, and then I was residency in Stanford. And she thankfully was willing to follow me there and go with me. But she herself is a scientist. She has a PhD in pathology, and she studies the genetic and genomic basis of pediatric leukemias, particularly one called juvenile myelomonocytic leukemia, or JMML. And she actually works for the University of California, San Francisco. So we'll be out your way next week. Actually, I'm going with her. She's going to do some work in person. She unfortunately doesn't get to do a lot of in-person work these days, but she was so good that they kept her on as a remote part of the lab. And she works for a pediatric hematology oncology physician who has a lab there, and they just do amazing work. They are literally taking blood samples from these poor kids who have a very tough kind of leukemia, and trying to develop diagnostic assays that will guide treatment and actual treatments in real time, essentially with the genetic material that they get from the hospital. So it's an amazing program. So that's how she got her connection out there while we were there. Then we said, where the heck are we going to go? We ended up in Minneapolis for my first job right out of residency. That was okay, but it was 2019, first job, first child, pandemic, all at the same time. So it was pretty chaotic there, and
I
we're
can
thinking
imagine.
a second child, and I said, would you consider going back home where your folks are? I really like it there. I think I'd love for our kids to be able to be close to their grandparents growing up, at least one set. And would you give this a shot, at least for now? And we came here, and it's great right now. I don't know if we'll be here forever, but it's wonderful right now, and I'm really happy growing into this community, being a leader in the community, setting up a dermatology practice, trying to touch a lot of lives, and just be involved. It's a wonderful community, and a lot of great natural resources too: ski hill, mountain biking, snowshoeing, hiking, all the. As
It's
long as you're
beautiful.
okay with the cold weather, it's a lot of fun stuff to do here.
So, but no, and that is a great. You went for a job, or you took a different direction, just not a traditional path, even for the practice wise. Tell us a little bit that journey. Not every specialist will be going to that immediate that with a lot of loans and everything else. You jump into the different direction. What made you to go that? independent direction that you choose? And then explain that direction too, if you don't mind.
It was it all happened a little sooner than I expected it to. I always had a hunch that I would do something more than simply working for a large health system as an employee. But I was comfortable doing that for the first few years to get my feet wet and understand, really get good at the way I like to take care of patients and understand those things without having to think about too many other things. Didn't think I had the bandwidth for that. And like you said, some people have loans. It's just nice to, you have a family, you want to be able to treat them well, and you've gone through med school, residency, all this, and not uh, um, having a whole lot of discretionary money to spend and all this. So having the job was nice in that regard. About 2 years into the second job that I had, the one that I took when we moved to Wisconsin, where I live now, I was kind of totally out of the blue, just terminated from my job without cause. So they never gave me a reason why. I have a hunch why, but they don't have to tell me, and that's part of the contracts. It's a state in which that type of employment agreement is allowed, and now I'm grateful that they let me go, and it wasn't really truly a good fit, and that's the only thing they did tell me. But the way they did it was interesting, to say the least. But nonetheless, as soon as that happened, that was a kind of a blow to the side of the head or back of the head, because I had no idea that it was coming, but I was kind of released into this path that I'm doing now. And I said, I'm never going to have a job again. I don't need a job. I probably shouldn't have a job, because I'm maybe speaking up a little more than I should as an employee, maybe kind of trying to behave more like an owner than an employee. So it makes sense for me to go my own way. And now I'm really trying to set an example for other people who don't think it's possible to be an independent physician now, insurance or whatever reason you make up in your head. There's a lot of stigma against that, and a lot of negative thoughts, limiting beliefs around that. So the reason I do my podcast and shows like yours, all of these types of things, is to give an example to people. The example that I didn't really have. When I was coming out, people just said, go to a university or get a job somewhere, because the private practice is really hard to do. And now I'm absolutely loving what I'm doing. But it's different. It's not a job. You don't just get this big old paycheck in a reliable way. You have to build it, and the returns are more, it's more exponential type of returns over time, and that's wonderful. But you really have to build it and take those risks and be willing to be patient. But I'm loving it. I'm ready. I'm ready to do it, and I'm glad that, in retrospect, I'm glad that they set me free in some regard.
In 1990s, I was here in the Georgia and Alabama area. I used to see a lot of independent physicians. That's the only way that practice by physicians, or most of them are independent, and the direct care practices. You can go to cardiologist, you can walk into a cardiologist, a radiologist, dermatologist, doesn't matter. Uh, Primary care. So everything was a fee for service. That was the model. And I used to set up their practices, and then also I used to place a lot of J1 visa doctors in rural areas. And so I traveled quite a bit of rural areas, and that was a great experience that I saw. That model went down with HMOs and IPA, the all kinds of big healthcare systems, private equities. They came in, they swallowed this whole system, and they really structured into a different world. And then nobody is happy. Doctors are not happy, the patients are not happy, and I don't know who is happy, but somebody is happy there. One of them, I don't want to mention the Wall Street guys.
Yeah.
Probably they're the happiest people. But this is a serious problem. It is not the entire country. Millions of people are unhappy with their healthcare system. It's a very important issue and a national security issue, in my view.
Yes.
So it is really swallowing. It's an American paradox. You're spending more money and then getting a less care. It's a paradox. So you took a path of direct specialty care. That is on the move as I watch it. Tell us a little bit your experience with the direct specialty care. What is that is all about? A little bit, a couple of minutes about it.
You bet. The I like that you mentioned kind of that the paradox, and I think about value, the value equation all the time. What you're getting, basically divided by what you're paying for it, and we are paying. We're getting not great care, not a great experience. At least we're great at saving people's lives and extending people's lives at the end, and fixing kind of acute things and doing heroic things in this country. And my friend and colleague, Dr. Bandari, when I was interviewing him yesterday, he reminded me of that. He said, I came here and I would not want to go, if I was sick, I wouldn't want to go anywhere else but America. And if I had a big health problem. And he said that's a big deal, but we don't, everything else downstream or upstream of that, we do very poorly because it's really not where the money is made, unfortunately. So I am approaching this in how can we kind of just take it back to where it used to be before the HMOs, before the managed care, and restore the doctor-patient relationship. And that's the only way that doctors enjoy doing what they do. So many of us are not happy because we signed up for something and then we got something else, and we aren't able to give people what we want to be able to give them, but they're still paying a lot of money, whether it's through insurance or deductibles, copays, whatever. And it's just it's demoralizing. So what I do now, I serve people in any way I possibly can. I take Medicare, I take Medicaid. I believe in those things. I don't believe I'm appropriately compensated for them, but I believe in participating in that to serve people who are being cared for with those types of insurances. And I'm a member of a couple just small boutique third-party administrators that help employers in the U.S. that are self-funding their health plans. They're finally saying, we're paying way too much for this. We can do better. And there are companies that are helping them do better. And one of the main ways they help them is they find independent doctors like me who don't have to charge these hugely inflated hospital prices to get an even better product. So so I'm in network with a couple of those. That's a work in progress. But the direct care point, that's the meat of it. If you're not Medicare, not Medicaid, and you're not covered by one of these networks that I have a contract with, I say, let's talk about what problem you have. Let's talk about how much a reasonable price for that might be, and we'll negotiate if we have to. Or you say, great. Most people just say great, and they because they don't have to wait 6 months, and it's not crazy. It's not concierge medicine, not $2,000 to see me, right? I mean, I charge quite reasonable prices, and I really over deliver. I will, the first consult with any patient, no matter what it is, acne, whatever, it's an hour long. It might not take that long, but that's what I block. And people are really struck by that. We get to know each other. We are not rushed. I'm not feeling rushed, which is great for me. And then the follow-up between the first visit and the follow-up visit is we actually use that time. They can text me. They have my email address, but people don't abuse that because they feel cared for. They don't feel taken for granted, and it's working so far. I will get bumps in the road, but so far it's just so nice to be able to say, hey, you want to get in next week and not wait 6 months, and it's not going to go to paying down your deductible, but it's going to be probably less than you would pay if you have a deductible. Going to be less than you'd pay for your 5-minute visit at the local hospital clinic. So that's kind of what I do. I just meet people where they're at, and I try. I mean, I took care of a local artist, and she paid me with one of her pieces. Right, and that's nothing illegal about that, right? It was. I'm having fun.
I saw one of your reviews of your patient. There's a rave review you posted. It's beautiful. That review by your patient that you gave, you posted it is really impressive. So let us talk about the cost. Let us shift the talk about. I don't doubt that you provide a more than a beyond service. That's why people like her. She posted that review. It's beautiful.
Mm-hmm.
But let us talk about the cost part of it. There is two ways you can do. One is a membership fee. You can do monthly fee or something. That's one way of some people with the some people have some kind of eczema and the constant is a chronic condition, or some people need a episodic care. So in the ways you can do membership, or you can do the flat fee, price transparency, flat
Mhm.
fee. You can do both, either one of those ways in the direct specialty care. Is that right? That is a model that you embrace.
Yeah, I have plans for membership type options for people who that is of value to them. My goal is to not make one part of my clientele subsidize another part, so that everyone feels like they're paying for what they want and what they need, and not uh, I'm not like using the relatively simple stuff that I'm still charging a lot for just because I can, to subsidize the people who need really those really long visits and are paying a similar thing. So I really try to match what the price with the service. And although I don't have those subscription models figured out yet, it is going to make a lot of sense for certain people, but not everyone. So I don't want to just do either or. I still want to have that option. You have a just some skin tags or a wart or something like that. I can take care of in a few visits or one visit. This is what it'll cost, and you'll get it done quickly, and I think you'll be happy. Or yeah, you have eczema, atopic dermatitis, and you are the type of person who understands that this is not just a creams and biologics and steroids type of disease. It's a whole person disease. It's a gut disease. It's a brain disease. It involves all of the systems. And you, in addition to being interested in the cutting edge pharmaceuticals we have, you also want to know, what can I do about my nutrition? How can I support my gut? How can I decrease my inflammation in general so I feel better and my skin also improves from that? That stuff is a much more, takes some more time. It's a longitudinal relationship and might make sense for a more of a subscription model but those are still in the works right now. I just negotiate kind of case by case basis if they don't if I'm not contracted with their insurance company, and that's worked well so far. A couple people say, yeah, I want to think about it because it is unconventional. Many people just say, yes, let's go. And it's not like I'm living in this isn't Palo Alto, this isn't Los Angeles, this isn't New York City. It's people have disposable income in most places, but they it's not like I think the
Yes.
misconception is, oh, you don't take insurance, how could anyone possibly pay for that? My response to that is, we're already paying for it. I mean, I'm fighting a bill that I got while I had insurance from a place that didn't happen to be in my network. So they sent me 6 months after I saw, they sent me a bill for that one consult for $640 or something like that.
Yeah. Is
That's
a,
much more than I would charge for my 1 hour visit.
this
And
is Go
it
ahead. Go ahead.
was 6 months after the fact. Here's your bill, a surprise. And the kicker is, it was a surgery consult, and the clinic was so poorly run that it had shut down in the meantime. So even if I wanted the surgery, I couldn't have gotten it. And they don't have the wherewithal to say, oh, maybe we should not bill him, or possibly not bill so much. It's just everyone's treated exactly the same. There's no personalization to it, and it's a myth. This whole who could afford that? We are already not affording it, but we're already paying out of pocket.
Yeah.
Everyone is.
So this is actually is where the advocacy is needed. The
Yeah.
status quo, that is where you force the organizations around you to do the price transparency and
Yes.
compare the prices. That is a requirement. That's where the fines are so minimal right now that they don't even care to publish their prices. So I think that is the advocacy in this area to go aggressive, and then that is where the direct specialty care really can play a role, in that sense, where they really force the organizations to publish their prices, and there is no surprise bills. That surprise bill act is there, but
Mhm.
still you need to have a price transparency crystal clear with the law enforcement, with the
Yeah.
with the with the with the, with the strength. That is a yeah, not only you. I am hearing from a lot of people from all around the country that their direct specialists, particularly, wanted
Mhm.
to go on their own, and they wanted to join as a specialist care, direct the care for the direct care specialty. That's their talking about it. But one of the things, you have an opportunity That's probably because I came from administrative side, I came from HMO and all this, uh, went through the ringer. I can suggest you certain things that one of them is in the Palo Alto area. They definitely understand, particularly a person with a dermatology or any other background, is that health savings accounts. You can tap into the health savings account. That's a biggest advantage there. That is a huge resource for you, huge revenue source for you. But in the rural areas, there is another kind of way you can play the role. Is that I mentioned in your introduction. The benefit managers, cities and counties, they pay huge amounts of insurance bills for the HMOs or anything. They don't know how to really separate them out. Put the primary care and then separate the direct care, and then they could save a lot of money that way by educating them, educating the benefit managers, educating the mayors. Hey, you could save a lot of money this way. This is a one. I think direct care needs a little bit of advocacy, a little bit of strengthening the process, and I think there is a huge people like you. You're not alone. I can promise you that there's a lot of people like you thinking about that, and I think there is a cohesiveness. And then, as you said, that and there is a your Lloyds of London people get self-funded, and they get the reinsurance from by the Lloyds of London or someplace, and then they could do. I did administer that kind of a groups before. I think that is a model is going to come back. People are frustrated, tired. If we're not going anywhere with this model, there is nobody happy. So I think you're on the right. There is nothing to regret, and I think you're on the right path. And it's also there are a lot of challenges, of course. You're fighting against the status quo, uh,
Right.
Dr. Lewellis. But I think that is a thing that people like you have to be a leader. That's what the leaders do. There is nobody. There is no precedence. Leadership is that is you advocate and you start the process, and then you show to other people. That
Yeah.
is a that is a there's a part of the leadership thing that you're a natural leader there. Let me before I do so I'm going to present you some scary topics, not as scary as the dermatology, though cell communication, some kind of physics topic. It is about the metamaterials. I'm going to bring that to you. That let me bring that little bit. Both of us can watch, and you can comment on any day. But maybe uh, your wife would be probably know a lot more than I do in this area. That let me get this. I don't know. This is a change a little bit. Everything is a little bit of a challenging nowadays for
Oh, I
me. Um, but this is a topic is very interesting topic that I wanted to bring it. Um, that the let me put this one as I can do this. Maybe I can do this. Yes, this is better. Okay, that is a Dr. Stephen Lewellis. He's a dermatologist. Is really, this is. I want to make this is a major one. I don't know how to do the bigger one. This one. Let me do. Oh no, I want to do this. Yeah, maybe change this. Uh-uh. This maybe this one. Okay. Anyway, I'm going to do this presentation this way. That next time I'm going to learn a little bit more. Uh, that is the that is the Dr. Stephen Lewallis from middle of nowhere. He's joining Wausau County. So I'm going to present a topic on the topic or interesting topic about this. There's a woman in Colonsay in the in the island of near British Island, Colonsay. Bride's mother was wearing this dress, for the wedding dress. And it is, everybody wears wedding dresses. Is not a big news, but it was printed in the local newspaper. And then some people said that dress is a white and a gold, and some people said that is a black and blue. Same people. That is just all of a sudden it became a viral.
Yeah.
Two people seeing the same dress, and it became a different interpretation they had. It became the global viral. it really integrated a lot of scientists in this area. So what is that is all about? That the entertainers got involved, and then the genius scientists Kanye West and the Taylor Swift, they were all involved, and they say Taylor Swift said that this is a gold and white, and the Kanye West said that is a black and blue, and then Kim Kardashian said that, oh, yeah, I don't know. Both of them she confused. So we need a rescue from Einstein for this kind of thing. So what is this? What is this all about? What is this? What is doing? So it is all about. Is interesting about is that this does eat us. I'm going to, our internet is also today is everything is a little bit of a challenge everywhere. So the it is a long range of the light. Okay, that's a long range of light you're talking about. This is a. I'm going to put this big screen here. Yeah, the language of light. What is this? Is something about the light that we need to understand. Most of the people understand the light part of it is, that in the high school they must have read about uh, the the yeah, it is coming up here. It's I don't know. It's not okay. So it is a long way of light. So what is it? Everybody knows about this, a little bit about this refraction, reflection means you see in the mirror, that is a reflection. Refraction is, you see the refraction you see when you put a straw in the water, that is refraction. And the diffraction is, light goes into in the evening time, the sun is disappeared, still you can see the clouds, the sun, the reflection. That's the diffraction. That's all common standard physics of the thing. That is, but there is another way of doing things. There is a light bench in other place. That is near the black hole. Actually, you don't need a mirror. If you look at if you're at the event horizon at the mirror in the black hole, you can see back of your head, because it goes around all the way, come back and see you. So you can literally see yourself in the black hole without a mirror. That is Einstein's physics. So actually, if you see that the what is the other one is I was trying to tell you, see the barber show that he's showing the very mirror. You need a mirror for the barber, but you don't need a mirror in the black near the black hole. You can bend the light. The black holes bend the light circularly, always almost in the event horizon. It all the things it bends is a complete. So you could see you don't need a barber there. You can see yourself in the back. So that is but there is another way of doing thing is the bending the light is so physicians can do that in the future. That is the uh, curving the light. Physicians can order now onwards a curvature of the light. You can curve the light. I'm going to tell you about that a little bit more. Why curvature of the you can bend the light and get a lot of medical diagnostics. I'm going to tell you why it does that, how you can do that. So it is a invisible man, as you know. People know. Have you seen a movie Invisible Man? You see that you see that really people think it is a fiction, but it's coming true. Let me tell you why how he does that. It is this is the this is the this is the mathematics already there. That's basically the idea of the manipulating the light and sound, or came from the French mathematician Joseph Fourier. He gave already mathematics. The Fourier transformation is called. So that is he gave a mathematics for it. Jagadish Chandra Bose is an Indian scientist. He was doing a polarizing the light through plants. He was using a jute plant to polarize the light. That you see sometimes, that you see in the 3D in the movies. Sometimes you wear that polarizer glasses. That is one of them. So there is a mathematics, and there is a structure, the infrastructure you can create, but there is a that's why they use that mathematics. Actually, if you see in the stadiums, you see here somebody talking, is not because amplification of that particular thing. It is actually you're using a Fourier transformation, because you're actually canceling all the waves, and then you're amplifying that wave. So it is you're using a very high level filtering mechanism, and then mathematics, Fourier transformation is a you have to send the same frequencies to cancel the other frequencies, and then L frequency is the only one comes out. That's why you could hear here. Otherwise, the whole stadium will be amplified. You cannot. So that is the mathematics behind it. So what is the so one of the things is, you see that light that I showed you, that Jagdish Chandra Bose. I think I spoke about that a little bit. So so the next one is engineering. Actually, that is this is the one. You got to be pay attention to it. So if you go to the restaurant, you see put a straw there, you can see refracted that, because the light travels in a different straight path. It take a minimum distance, so it has to refract, and you see that on the left side. But you never see the one on the right side. That is done by two scientists. One is Dr. Smith, another one is a Russian physicist. He actually gave a physics to it. You can do it physically. It's impossible. People thought it's impossible to do that. Is a positive refraction, negative refraction is, you see that refraction on the left side and the refraction on the right side is not possible, they thought. So that was the biggest challenge. But in the Duke University, they solved that problem. They first came out and showed that. Once it showed that, there is a new kind of science evolved. And the new science is origami. Is a Japanese-based origami is inspired origami. So you can bend light in different ways, twist and turn, and all those things. You can using just origami kind of model, and then you can use the materials, special materials. You can twist the light in different ways, running around. You can bend the lights. Bend. That is a it's a material. It does that. A particular material, the way you do that is a particularly, they are called meta materials. That's what they call. These are the meta materials. These are engineered man-made materials. These are engineered man-made materials. I'm trying to make it a little bit bigger, but I can.
Okay.
My eyesight is getting worse. These are the. Let me bring the side, if I can bring him side, maybe this side. No, this. How do I make it this bigger? This is the. This is the one that is bigger. So that's what is a little bit of a challenge for us here.
There you go.
Okay, now that's what I want. Okay, that is the meta materials. They're made from a special. It's a totally engineering. It is an amazing. It is a really, you see that meta materials are um, made by alloys and different materials. You do use almost the refraction. It becomes almost a very different refraction. They do that, and then you can bend the light the way you wanted it. So metamaterials are new kind of a materials that can change the healthcare itself. So you can make it disappear, because you can bend the lights. So if somebody is coming towards you, if I put a metamaterial around him, you cannot see him. That it looks like a transparent. You see through directly behind him. You don't see anything. Somebody is coming to you. It is possible. There's a bending light waves. That is of the metamaterial property, is a bending light waves. My um that is. So what it is, you can also make it disappear, people. So actually, that was a real picture in the middle. So metamaterials can you can hand the disappear on the left side. You see that? So metamaterials can make that you can make a metamaterials to disappear, and you cannot see anymore. So it bends. The light waves are bending. That's what it is doing. Is curving around that material. So that is the power of disappearing man. All those things he can make it function. But the real thing is that it is really used in a it is a it's a really arsenal in the front. Is going to be a great arsenal in the war. The reason was, actually, his name is Fedorov. Mikhail Fedorov is a actually is a Ukrainian minister, is a scientist. Actually, they made him a deputy chief minister, prime minister. Actually, what he did was he invented. He was a IT. He was the head of the IT information technology for the Ukraine. He discovered. He invented a blanket, the invisible blanket. When the soldiers or get hurt or injured, you can throw the blanket on them so the other people cannot see, so the enemies cannot see them. So he actually presented this thing in the defense symposium in England. Actually presented this blanket. So is a metamaterial is going to be a great arsenal in the future. I don't know if it's good or bad, but it is going to be the future. So the next one is that. So in healthcare, where do you see in healthcare? What are there's a lot of applications you could see in healthcare in the metamaterials. I'm going to show you. I am one of the things is that in healthcare you see that traditional you see that mammograms very expensive, bulky machines. I used to we used to do a mammogram in our offices. I used to run the office. That is, we used to do mammogram. It's a huge machine. It's a bulky, and it's a very painful, in fact, for a woman, and it's costly. And we never used to make very expensive. So it is the machine is expensive, the procedure is expensive, everything is, so it's very required. As a mammogram is a screening is a 1 in 8 women are getting a breast cancer. We need that. We need a very powerful arsenal in the fight against the breast cancer. So this is metamaterials can change that entirely. Can you believe that? What it can change? Metamaterials, you build the you build through metamaterial. Radio imaging, they use the radio waves. It's already there. The equipment is very small. You can handheld the mammogram. That's machine basically. You can rent it from a grocery store or a drugstore, and then take it home and you test it yourself. Is that easy? Is going to be that easy? Is affordable, affordable, and that's going to be saving millions of people's lives, particularly women. We need it. So I think the metamaterials are going to change the game of these machines. Is a huge. You don't need a big mammogram machine. Metamaterial machine is this radio imaging. The use the radio waves, the other end of the spectrum of the electromagnetic waves. They use that, and then it's a sensitivity is a much higher than a mammogram. So that is going to be the future of the screening test. For example, if you think about MRI traditional, for example, there is a huge machine MRI, right? The MRI is expensive, costly. It's not too many. It's not accessible in a lot of places. In India, we have hardly any. You have to go through a big city, 200, 300 miles to go to get an MRI done. So in the other countries, it's extremely access is a big problem for MRIs. So metamaterials can change that. One of the things which is going to change is actually fan looking. It look like a drum. You see that? It is going to be the MRI is going to be that size. Radio is going to use a radio imaging to change the size of the MRI, that you can do knee scan there. You can do metamaterials can reduce the size of the machine to the lowest level. You can imagine it uses the no radiation, no CT scan, radiations there. So you can use basically is a radio waves. The radio imaging it is. So it's affordable and portable MRI machine. This is it's going to be the future of the medicine is going to come in. It is science fiction. But deep in the abdominal, one of the biggest challenges pancreatic cancer detection. I'm not a doctor. Dr. Lewellis, he is the one who can tell you. But it's a very difficult one. It's a deep in the abdomen. It's very difficult. I used to in the lab that I used to run, the radiology lab. This ultrasound is one of them. It's always difficult to find the pancreatic the pathologies, because that, and particularly obese patients you have is another challenge. A limited sensitivity ultrasound doesn't have that kind of power to do to find that pancreatic cancer pathology. So metamaterials can do that. It is, if you make the ultrasound the materials through the metamaterials, it can penetrate the size. It can use shortest wavelength it goes. It is unimaginable resolution. It will come back. It will see the cyst and everything. So we can, in the future, we can detect a pancreatic cancer way in advance. We can save millions of thousands, if not millions, lives. This is the biggest challenge for the pancreatic cancer. Is one of the toughest one to diagnose. I think we have a new material, metamaterial, can really help in this game. The next one is the cancer detection. Is actually the cancer, the contours that you see. It was Dr. Lewellis is talking about a photo that the radio, the photosensitive, that you can see the photo that radiant. That my English is not 100% good. Lightening up the cells. That photo, that thing that light up. So you could literally see the dead cells versus the living cells. You can see the contour very well in the cancer area. So it's going to be made by metamaterials. But the favorite one is the next one is my the most of the surgical instruments, they won't vibrate anymore because they're made from metamaterials. They won't vibrate. So these are all benefits for the healthcare from metamaterial, pure engineering and pure physics. Think about that. What physics is giving it to the humankind, mankind. So there's a feature, the stroke detection. You can see while you are on the way to the hospital, you can detect pathology, completely diagnose through metamaterials. Just plug the hat there, and it can tell you everything about it. It is an amazing things are coming up in the metamaterial world. There's a lot of research going on. So the metameri and the if you talk about the stents, for example, if they're made from metamaterials, they don't degrade. And then there is other infections come around it. So you can really change through metamaterial a new kind of stents you can create, and meshes. And a lot of people use stents, as cardiologists and all those guys, as so these are all big drug stents, and all these stents you can use a metamaterial stents. Really, that's going to change the game. So what then I'm going to talk about is, then if it is I hope I can show you at the end. Probably I show you. I don't want to change this thing. If I change it, it's almost I'm going to show you at the end of the video how the glucose monitoring blood glucose. Just to wave the hand, it will give you blood glucose levels. So made from metamaterial. Just wave the hand, that's it. In between, it will give you the blood glucose levels. So there is another fun fact. There is a gossip talk. I'm going to do a little bit. These are physicians can in the University of Washington. They do this kind of a lot of things are building up. There are a lot of sensitivity. These are all the new things are coming. Endoscopy. Sorry, this is endoscopy. You can do really literally see the bending the light. You can see through the everything in this one. That is not the shades. We have a lot of shades come out of the endoscopy when you do upper or lower endoscopy. It doesn't matter. So there's a lot of shades come out. But if you send the bending light, you can bend the light. So you can see literally there is no shades in it. So you can see the pathology much clearer. I'm a physics. I'm not a doctor. I tell you, as much as the physics side of it, that's all I could do. Anything that I do wrong in the medical side, excuse me, you have to pardon me about that. So it's a glass fabs. It's the way they make metamaterials, or you have to do with utmost precision. They do. I see fabs here in Silicon Valley. Integrated circuits. You need a similar kind of a lab fabrication you have to do with a high level, high sensitivity places. You got to develop that materials. So it requires a very highly sophisticated fabrication. The labs you needed to do the fabrication for that kind of a material. So the I, 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 I am going to move. I'm moving. I think I moved it. Yeah. So there is a lot of companies or I'm not just making up. These are the companies working on TerraView, Meta Beyond, Go Beyond, Murata Manufactured Company Limited, and Multiwave Imaging. These are all of the several companies. Some companies are all in this process. They're producing a lot of materials, the cameras and everything. They're doing that. There's a bunch of companies are involved now. Slowly, they're joining in this new revolution, in the metamaterial revolution. But there is a lot of talk also. They say aliens use a don't check on me. I'm a physicist. I'm going to talk a little gossip here. But they say in Las Vegas there is a place that all the UFOs, all their things they stored, all of them are they found out is through metamaterials. They are using metamaterials in that one. So Dr. Stephen Lewellis, if he gets access to it, he can tell us about it a little bit more. so so that is the world of a metamaterial. It is a really we're going to change. So I'm going to go back to the metamaterial is going to change the world of healthcare in the future. We are on the cusp of a revolution. But let us talk about the reason I did this one to understand the light is nothing to do with the metamaterials. They are not made from metamaterial. It's actually it is the reason was is a brain interpretation of the dress. It is a big news, because this is the way it is a background. Our brain actually calculates, and it just basically assumption. It does a gross assumptions. It does about colors, everything. So some people who are in the background, it is also it depends on the background and inside, outside, or just your way of trained eye, all these things. All pathologists is involved. It is a little complicated, as not as simple as that, but that is the case. That is, if you see that actually simplest explanation could be still beyond the explanation is beyond this, but is a background is you see that one background is you see gold and white, other one is a blue, black and blue. So it has nothing to do with the metamaterials. But if they're metamaterials, they will be disappearing for us. But anyway, thank you for listening. I hope I gave you something different from physics side of it. I'm going to bring a Dr. Lewellis back. So let me bring it. Let me hide this. Yes. So what do you think, Dr. Lewellis?
I love it. I love learning from a great teacher and people who are really passionate about these things and are willing to remember the history and walk us through those type of things, because it even though I don't have the mind to think like these physicists who grasp the mathematics and it can somehow think like when I think about how Einstein just came up with these theories, because he just said, I think I just it seems like that's how it should be, but then you put the equations and all that, and you have to put pen to paper to actually demonstrate those things. I just love learning about that, because even if I pick up one small thing, I can then bring it eventually to some other part of my life and some interaction with a patient or something that I'm thinking about, some idea. And that's only when you reach a certain part time in life and you've consumed enough that you start to be able to make those connections. That's why one of the reasons I love your show is that it's bringing all the bricks together, and it's not forgetting all of these things are truly connected, even though they're not obviously connected. And it's also just fun to learn from
Thank you for coming here. That compliment means a
yeah,
lot to me
absolutely.
from you, coming from you, from
It's
a
great.
Stanford-educated doctor. As a truly an honor.
It's
Doctor Dr. Lewellis, you're in a Let us talk about this direct specialty care. You think that it's going to the model has to be changed, right? We have to change. What do you think? How the people are responding to you when you present this? If you can change the rural America,
yeah,
like places like Wisconsin,
yeah.
you can change rural America. You can easily change the rest of America much easier. you
Yeah.
know that. If I can change somebody in rural Georgia, that definitely everybody that accepts it. So tell us what are the how you can approach that. Give us a little bit of insight into how you talk with that rural Americans are true or they don't know all these. Uh, Complicated mechanisms of the payment, reimbursements, and deductibles, copays, and how do you explain them simplest terms for these things, very way to they can understand and say that is really you're adding a value to them.
Yeah. Good point. It's still a challenge to a large degree, but that doesn't mean not it's not worth putting yourself out there and telling people that you are there to deliver a service that they want. And that's marketing and that's sales and that's something that physicians shy away from largely, and something that also they just have abdicated to big corporations. And that's why part of why we've gotten to where we are. It's not just the corporate side of it is to blame. It's also the doctors who have said, "Yeah, I don't want to do anything but take care of patients," right? But if you involve yourself in all of the aspects of it, and understand what good marketing is, authentic marketing, not sleazy marketing. It's just getting your message out to people in a way that defines the problem, speaks to them about their specific problem, and it presents a value proposition. And that is it becomes relatively easy, but you have to study that just like you have to study embryology, or you have to study cardiology, or and learning any organ system. It's the same thing because it's the same fundamentals. There are essentially almost immutable laws in terms of what works in marketing, psychology, all of this. And you can still do that in an authentic and ethical way. So that's what I focus on. I study those things and I try to bring those to the way that I sell my practice and my service. And then you're right, you're not talking about reimbursements, and I'm not complaining to people about, oh, insurance gives me this only this much, so that's why I don't take your insurance. I'm not talking about that stuff. I'm saying this is what I can do. This is the value proposition. You're going to get in sooner, you're going to have a better experience, you're going to be with me longer, and those are all things that you're frustrated with within the current system. And it's still going to be a reasonable price, comparable to what you'd probably be paying if you happen to have a deductible. And they take it or leave it. And more people will come around to that. And I only need to get a few people, because then they'll tell their friends. They'll be my marketers, and that is, and there's going to be more doctors coming to people like me to learn how to do this, and that's good. It's easy for me because I'm one of the only people doing this in my area, so it's easy for me to stand out. The arbitrage there is going to disappear over time. Anytime you enter a wonderful market like this, where it's just it's there's so much opportunity, that will eventually decrease as people realize that and they enter that market. But that's good. I want more independent doctors in the market. I want another independent dermatologist down the road to help me take care of all the people who need to be. But to your point, the way I'm doing it is just speaking in very plain language. This is the problem. I recognize your problem. This is how I can solve it. And if I do a good job selling that, they're going to buy it.
I'm trying to do is put a small group together, like a small non-informal kind of thing. I'll explain to you later on, but I think that is going to be the future. Our mutual friend Diana Langonia talks about authenticity and the trust. That's a
Mm.
very important ones to present to the all the public. Thank you so much. If you are coming with your hi, how are you? Hi. Oh God, yeah. I am done with the growing up. My children are grown. I don't now you're being trained. Say hello to the
Yes,
entire world.
I,
From Nepal, India, United States, Silicon Valley.
you bet. So I'm glad you came in. She's about to go to bed, so she wanted to
What
say
is what is the name?
her name is Maya. This is Maya.
Maya. Oh, beautiful name from Nepal. You got the Buddhist inspiration there.
Yeah, yeah.
Thank you. It's truly honor to talk with you, Dr. Wallace. It's always pleasure talking with you. It's always educational. You're a leader. You're a natural leader. I have always admiration for you. Thank you so much.
Thank you.
Bye, Maya. Bye. Bye,
Thank
Dr. Wallace. Say hello to your wife. She's
If
a
eventually
PhDs have a
will
special
start,
love
we
for the PhDs.
thank you. Please reach out to me about the group that you're thinking about putting together. I think the more of us who are independents, who are working together and sharing our experiences, the more power we'll have. Because I think independent physicians can still work in numbers, like the Independent Physician Network. Independent Physicians of Wisconsin is a group that I'm exploring, and that matters because we can have size while remaining independent, but we can use that leverage for good.
Thank you,
So,
sir. Thank you for coming on the show. It took your time and you explained very well. Thank you all so much. Thank you.
thanks
Really
everyone.
wonderful. Good night, all of you. Let me. My new technology is always challenging. This technology comes in new. This is called entropy. More features you add, more entropy increases. They say that's what happens to all of us. That's what is a that's one thing, something we need to learn on that one. But yeah, yeah, I don't know how to where these things go. But I'm going to play this my end final question. Bye. Good night, all of you.
Telling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it